So Cindy Bateman's my very good friend. We've known each other forever. We've been in this field together, and she's been a powerhouse in our field. She has been one of those people that connects the field and makes it feel like we're all in this together. So under that, I'm going to say that she developed the Clinicians Coalition with one of our own patients. Families and that we share. And she helped us develop guidelines together under that. She was on the IOM panel with me when we were doing the case definition. She's been on every advisory panel that I can remember for as long as I know. And now she's really an important position she's playing a role in that I'd love to hear more about is her work in the recovery initiative, because when the recovery initiative first came out, they literally threw MECFS to the side and said, we have no interest. But then they realized, ooh, did we make a mistake on that? And Cindy and her team have been the key players in the recovery initiative's efforts to understand that MECFS does have much to offer in our understanding of long COVID, and that it should be an illness that is studied under the same umbrella. So if that's a good enough introduction. I don't know what the other one said, but that's a good introduction. She runs the Horn Bateman Center down in Salt Lake City, which she developed herself. It's a nonprofit. They're doing amazing work for patients, for the region, and for the country. So there you go.
Well, thanks. Yeah, I mean, my work in Recover, I feel like I'm a sacrificial lamb in there on that federal committee, but really it's been a great opportunity to speak for MECFS and to try to be a teacher in that setting too. I've really tried to focus the last part of my career on education as much as possible. And I see, you may see Talia on the call. Talia has been our education director for a long time, and now she just got promoted to the director. What is it? The executive director of our organization. There she is. But she's been behind our educational efforts. We started this during the pandemic, right? When our research got kind of frozen and everything got kind of frozen. So, and we've really pivoted from patient education to provider education with a strong emphasis on reaching out to providers who don't already know about these illnesses. It's really daunting, as you know, because when we try to interface with the rest of medicine, they're not very receptive. So I'm working on a talk to try to, in very practical ways, help people understand about orthostatic intolerance syndromes and to be able to handle them in the office. And I'm kind of bouncing some of this off of you today. You may be way beyond it, but what I'd like to do is share with you some of the things we've struggled with and tried to learn how to do in our clinic to provide relief for patients with orthostatic intolerance. So I think I'll go ahead with that, and feel free to interrupt me while we're talking or save things up and we can talk about it in the end. But I'd really like to kind of share experiences with you. So some of this may be just a little bit basic because I'm speaking to the choir, but this is just to remind you that we're a nonprofit, and we're a nonprofit that focuses on clinical care research and education. And our focus is really on MECFS and related conditions. It used to be more on fibro, but now I think most patients are getting what they need with fibromyalgia. And then, of course, we've embraced the more broad view of with long COVID and other related conditions. We're really learning a lot clinically. Thanks. Talia, go ahead. And just for it, so we all have the same terminology, I'm using the term orthostatic intolerance kind of broadly. I actually prefer using the term orthostatic intolerance because I think there's a lot of underlying manifestations that fall under that umbrella of orthostatic intolerance, and I think it's better to teach clinicians to use that term. Next, please. And I also want to remind all of us that we're talking about chronic orthostatic intolerance when we're talking about these syndromes, and we really should remember, and the first step I always try to do is remember that there are cardiopulmonary causes. Next slide. And drug side effects. One of the most common drug side effects that gets missed is drospirenone, which is a progestin, and I've really improved some people's orthostatic intolerance simply by looking at the meds they're on and minimizing the negative impact. But of course, we're really thinking about disorders that are related to the central nervous system and the peripheral nervous system, even though we don't totally understand, especially in long COVID, what all the factors are that lead to this this autonomic dysfunction. But orthostatic intolerance is really surprisingly common in post-viral syndromes. Next slide. And of course, we all know these definitions, defined syndromes that fall under the umbrella: orthostatic hypotension that's supposed to occur in the first 3 minutes, at least 20 reduction in systolic pressure and 10 in diastolic, and a commonly used umbrella of POTS, where the heart rate has to go up 30 unless it's an adolescent, and then they go up 40. And there's presumably should be a stable blood pressure in these patients. And then there's a bunch of terms. Peter Rowe kind of coined neurally mediated hypotension, but I think when we get out into the bigger world, we should remember that they're similar or almost synonymous terms that are being used: vasovagal syncope, neurocardiogenic syncope, etc. But it's basically sudden syncope while upright. Next slide. But this is a really good paper that people should take a look at if possible. This is a paper, a scientific statement from the American Heart Association that was published just in November in Circulation. And it's a whole paper about autonomic dysfunction. And in the section of this paper, there is one specifically on it's on cardiac arrhythmias. And there's a section specifically on autonomic dysfunction in COVID-19. And in this paper, it says that POTS is in 25 to 35% of patients with PASC, and orthostatic hypotension in 3 to 5%. And then a little statement there about that we don't really understand these mechanisms, but immune-mediated causes are likely, whether it's autoantibodies or against autonomic receptors or the peripheral nerves or upregulation of pro and family inflammatory cytokines, et cetera, et cetera. And it sounds like it's like a deja vu, right, from what we've been thinking about ME/CFS all this time. Next slide. But there's this great diagram in the paper that I think is worth looking at. And that is that of the people who get PASC and have autonomic dysfunction, it looks like about 35 to 40% have POTS, and a small percent have orthostatic hypotension, and a few have inappropriate sinus tachycardia. That's the yellow. But look at that big green section that's orthostatic intolerance without that are normotensive and without tachycardia. And that's also something we see in ME/CFS. And what I love about this paper, I wish every cardiologist had seen it, but they said that as part of a complete history and physical, orthostatic vital signs in the form of a 10-minute stand test should be done with every patient, and they're sufficient to delineate autonomic dysfunction. And even though it may be a new disorder, a new clinical entity, and it's possible that the autonomic treatments that we have existing may be ineffective, it's also important that we should manage according to the existing autonomic disorder guidelines. And they're really out there. There's lots of good literature about how to manage autonomic dysfunction. It's not perfect, but every primary care doctor and every cardiologist really ought to be able to screen and initiate treatment for autonomic dysfunction, especially orthostatic intolerance. Okay, go ahead. And I just want to remind us that we've really been knowing this in the ME/CFS population, right? These great patients by Van Kampen and company that have shown that even in the absence of hypotension or tachycardia, the cerebral blood flow is reduced during tilt testing. It's not related to it's not only from deconditioning, and it hangs around a while. So cerebral blood flow remains reduced after the tilt table test in ME/CFS patients. So I think my personal feeling is we've missed orthostatic intolerance in ME/CFS from the very beginning, really to understand how prevalent it is in the clinical presentation. Next slide. So I'm just going to go through the very basic assessment and treatment that we use and some of the tools we use in our clinic. And I'm going to talk about these three things. We apply a measure called hours of upright activity. We use orthostatic hypotension questionnaire, and then we do 10-minute lean testing. Next slide. So I don't know how widespread this is, but I actually took this from a talk given by David Bell at the State of the Knowledge workshop that was, gosh, about 10 years ago. And I borrowed this term, and we've used it in clinic ever since. So we have patients report subjectively about the hours they spend with feet on the floor in 24 hours. So you've got to make sure that they understand how we're asking this. So sitting in a chair with your feet on the floor is upright as well. So anytime your feet are on the floor, and we also ask them the balance of, the other numbers, these to add up to 24. So the time when your feet aren't on the ground, but what we're looking for is hours of upright activity. Next slide. And what we've seen in our clinical data, and I just estimate this myself, but if you think about the time you spend with your feet on the floor, it's usually 14 to 17 hours a day for most people. As we age, and if you've got fibromyalgia or a chronic illness, it might come down to 10 to 12. But what we see in our ME/CFS patients is 0 to 8 hours of upright activity. And you really don't realize this unless you ask. But I've never seen anything like this, really. So this has turned out to be a really reliable measure and report from patients that we do every visit in our patients. Next slide. And then here's the orthostatic hypotension questionnaire. This is available easily online, and it has 6 domains that assess symptoms and 6 domains that assess activities. Next slide. But we decided after some hit and miss that the word hypotension was misleading and confusing to patients. So we've changed the wording of this orthostatic hypotension questionnaire, next slide, to say orthostatic intolerance. And I actually talked them into doing this in the RECOVER clinical trials that we've been doing, because orthostatic intolerance is patients say, I don't have orthostatic hypotension. They don't know what it is, but they know they've never been diagnosed with it. When you just give them a brief description of orthostatic intolerance and have them fill out, you have to all the verbiage in the questionnaires you have to change to say intolerance instead of hypotension. When you do that, it becomes a really good tool to ask patients. We even tested this in our clinic. Next slide. In a study we did. So this first slide is kind of busy, but this first slide is asking about those first 6 symptom domains. Okay, and just look, and there's a score of 0 to 10 in each domain. We had 25 people in our healthy group. Look at the blue column. And there were, if you go down, you can see that the average score was barely 1, right? 1 out of 10 in healthy people. Then we had 26 ME/CFS patients, and we grouped them according to their hours of upright activity and labeled them mild, moderate, moderate to severe, and severe. And then we put their symptom scores using the orthostatic intolerance symptom assessment. And if you look across, let's look at dizziness. You can see that in healthy controls, it was 1 out of 10. Mild patients was 5, mild to moderate 5. Then as you go to moderate to severe, 6. And when you get up to severe, they score a 9 out of 10 on dizziness. So you can look at this questionnaire and immediately see how patients with ME/CFS space out from patients from the healthy controls. Let's go to the next slide, which is the activity interference scores. These are the other 4 domains, also scored on a score of 1 to 10 for each domain. And you can see that as the healthy controls rarely score more than 1 to 1.5 on a score of 10 on this standardized questionnaire. But the sicker the patients are, particularly standing a long time and walking a long time, you can see they have very high scores. So some people use this on a total scale of 1 to 10, and some people use it on a scale of 1 to 100, but it doesn't matter. You can see that the spread is tremendous, right? And so this is a really good clinical tool and doesn't take very long to get an idea of how much orthostatic intolerance is affecting people's symptoms and function. Next slide. So what about the third tool that we use? Well, this is the 10-minute, is 10-minute lean testing. And we could talk about using a stand testing versus lean testing, but those of us in the field of ME/CFS have adopted the 10-minute NASA lean test and pushed that out. And I really thank Benjamin Nadelson for teaching us about this and labeling it the NASA lean test. But there's a paper submitted for publication right now that came out of the CDC-sponsored multi-site study that's going to show that autonomic dysfunction is really widely present in ME/CFS in its varied forms using the 10-minute NASA lean test. Next slide. So, this is how we do it, and I think everybody does. It's a standardized passive stand test is the correct description. It's an active stand test if you stand straight on your, without leaning, and it's a passive stand test if you lean against the wall. And then you collect measurements of heart rate and blood pressure supine, resting, and then every 1 to 2 minutes while leaning in this posture. And the posture is really to just put your shoulder blades against the wall and not put your whole body against the wall. There's a little bit of airspace as you go down, and the feet aren't too far forward. You want your patient to be in a relaxed, stable position. We like the lean test because I think it's safer in the office, because if patients faint, you can kind of slide them down the wall. And we always have 2 people monitoring when we do the lean test. Next slide. So, okay, let's go through some very brief management approaches. Next slide. So this is a male who came in who'd had long COVID for 7 months early in the pandemic with absolutely no one to help him. And they couldn't tell why he couldn't function at all. And if you just look at his intake vital signs, so it's a 120/80 and a heart rate of 82, you would easily pass this up, right, and not understand how much orthostatic intolerance was contributing to his inability to function. But of course, you can see his heart rate supine is at 65 and went right up to 138, just climbed and climbed, and he did not make it all the way to 10 minutes in the lean test. So you can see his blood pressure was relatively stable, although you get this narrowing pulse pressure and the diastolic pressure comes up. Test was terminated early. His heart rate went up to 73 beats per minute. And this is POTS, right? There's an approach you can take. Next slide, let's see what we did. So, the treatment approach, we always start with fluids and sodium and based on people's age and their tolerance for that. And then it's not really clear, there's a little bit subjective what you decide to add, but I usually prefer beta blockers in a case like this, but then Ababardine is also really, really helpful in many patients. Next slide. This is a call I got from someone early in the pandemic, well, later in 2020, who was really desperate for some help. And so we did this remotely. She's 65. She was a very successful, healthy 65-year-old who had just barely retired. And she had COVID in the spring. And when she tried to go back to exercising in August, she had a major crash and really had her whole presentation met criteria for ME/CFS very briefly. But you can see rapidly that she has systolic orthostatic hypotension. We had her have her physical therapist come into her house and just do this in her home. And knowing this she really should have had a better heart rate response to this, right? But she dropped her blood pressure massively. But I want to tell you about a measurement we've been using in our clinic, which is the ratio of the pulse pressure to the systolic pressure. And this comes from intensive care when they're monitoring for shock. But the ratio of the pulse pressure to the systolic pressure should be greater than 25%. And you can see hers dropped to 20. Next slide. And really, she responded to very basic interventions as long as she understood what was going on. And we taught her about her pacing her activity, being awareness of her body position, really increasing oral fluid. She had hypertension as well. But this helped her to do very well. She was never able to go back to very vigorous exercise. Next slide. I just wanted to show you a couple of studies we published that have convinced us we should be looking at this ratio of pulse pressure to systolic pressure. This was a big study. We looked at a study. This was part of the collaborative research studies with JACS, but we analyzed our data, and there's a change in pulse pressure in every patient, even healthy controls. So in this, the minutes of the stand test are across the base, and then that ratio of pulse pressure to systolic pressure is on the x-axis. So you can see the line that are marked with X, those are healthy controls, and the little triangles are ME/CFS patients who've been sick longer than 10 years, and the circle diagrams are ME/CFS patients sick less than 4 years. And you can see that the early onset patients really drop the pulse pressure to systolic blood pressure ratio below that threshold of 25%. And that was statistically significant. So we were trying to understand what could we look at in our lean test data to show that there was a problem when ME/CFS patients stood up, because it was so variable. Next slide. Then later, we published another paper on orthostatic challenge in long COVID patients compared to our ME/CFS patients. So this is, again, the minutes of the stand test across the base and the pulse pressure to systolic pressure on the side. And the yellow is throughout the lean test, this ratio stays well above 25 in the healthy controls. Then in the ME/CFS patients, and this is all of our patients, that includes the early onset and the long, you can see it's lower, but they don't usually go below that 25%. But our long COVID patients, their pulse pressure ratio, which I use as kind of an estimate of cardiac output, a rough estimate of cardiac output, you can see goes way down in those with early post-viral syndrome dysautonomia. Next slide. So very basic, this is what we teach people about managing orthostatic intolerance. First, understand what aggravates it, what makes it better, what makes it worse, getting overheated, dehydrated, standing in place. The more you can educate the patient about the behaviors that will worsen their orthostatic intolerance, the better. I think patients should be very empowered to understand how to manage it. And of course, when you're in post-exertional malaise, it tends to get worse. And there are lots of flares of the dysautonomia that can also worsen it along with post-exertional malaise. Next slide. Then basically anything that increases volume, so extra water, fluids, salt intake, fluticortisone, rapid water ingestion, IV saline, and then desmopressin is not used very often. I don't advise it to very many people, but it's very, very effective at immediately raising the intravascular volume and adding a pressor effect. And I use it in very select patients. Once people are on desmopressin, they don't have to push fluids very much. You can almost titrate their intravascular volume and pressure using desmopressin. I often combine it with fluticortisone. But it's easy to get hyponatremic if you're pushing free water. So once people get very balanced, you can use this, but I am very, very select about it. So then anything that compresses blood vessels, so compression socks, and the more compression you wear all the way up to the abdominal binder, the better. And then Metadrin is a peripheral alpha agonist that it basically does the same thing as compression. So it constricts blood vessels in your arms and legs. Okay, next slide. Then the next is to control a rapid heart rate response. But I want to say we don't jump to this right away because, and I'll show you more Because, if you're hyperadrenergic POTS, if you're like that first one, then you can really dampen down the heart rate. But sometimes dampening down the heart rate is a bad thing to do. So we're very careful and generally use low-dose beta blockers, ivabradine, sometimes clonidine and that family of drugs, especially if you want to get people to sleep or they're very, very anxious and if their blood pressure will tolerate it. And then I absolutely love pyridostigmine, and I'll show you why. And it's tricky to use, but and there's an early paper that I've footnoted there about how it can be helpful. I like to have a little bit of evidence for why we pick these meds. All of this is out of the dysautonomia literature. And then last is to strengthen the muscular pumps and use them and teach patients that if, they all know this, walking is better than standing. And if they can do strength exercises for their abs and their lower legs, that just helps as well. Okay, next slide. So, and then last of all, to the degree that people can do exercise, and it really has to be adapted, of course, to the severity of the illness. But I always focus on lying down, seated, more supine movement ideas, and especially in the water, because you can rehab anybody from any level, either when they're horizontal in the water or they're vertical in the water because of the increased pressure. Next slide. So let's look at some cases and see why. Sometimes it's easy and sometimes it's not. Next slide. So here's a woman, a young woman who you can see supine, has pretty lowish blood pressure, 102/76, and heart rate of 75. We might think this is really healthy, right, in healthy people, but even her pulse pressure over systolic pressure is a little bit on the low side. And the normal pulse pressure as people get older is about 40, right? We say 120/80, right, is a normal blood pressure. That's a pulse pressure of 40. So her pulse pressures are a little bit low. And then when you look at the ratio, it's just barely over what we could consider normal for good perfusion and cardiac output. But when she stands up, you can see her blood pressure becomes really difficult to hear. Her heart rate goes up, but and it does go up 43. So this meets criteria for POTS, but you want to be careful because she's already got a very low blood pressure, right, and perfusion. And so when I have this, I would like to start having people in their mind, what would you do first in this person? The other thing about the Nasoline test is you record symptoms and signs, which is really, I think, helpful in the chart for disability. So we always put down the things that are spontaneously said and also the observations of the clinicians who are doing the test. Next slide. So from my standpoint, I would start strong with fluids and sodium in this patient to really increase intravascular volume first. And you might be surprised, that might be enough to compensate for that POTS response. I would also go to midodrine and compression. So you increase volume and you increase squeeze, and this person's heart rate response might come down quite a bit and not meet POTS criteria anymore. You wouldn't have to go to agents that slow or cap heart rate. Next slide. This is a 47-year-old woman who, this is a kind of a ditto, but here's this person that looks pretty normal, lying down, good pulse pressure of 54. That pulse pressure gets bigger and bigger as patients age, as you get more vascular stiffness. And then when she stood up, you can see it drop down immediately. So at 3 minutes, 2 and 3 minutes, she met criteria for systolic orthostatic hypotension. And you can see if you look, as long as the diastolic doesn't drop, you can use that equation of the pulse pressure over systolic pressure, and you can see that went to 13%, went from 46 to 13%. Think of that as her ability to perfuse, the perfusion pressure, the cardiac output. So next slide. And I think she has, I would call this chronotropic incompetence as well, because she really should have gotten a more rapid heart rate response to standing. And that you wouldn't want to give her anything that slows that heart rate in addition. So again, fluids and salt, fluid cortisone if it helps, midodrine monitoring heart rate, because it can sometimes slow the heart rate as well, compression, and see if you can get this compensate for this big drop in systolic pressure. Next slide. This is a patient who came in, and sorry for all the different formats. I'm trying to decide how to show these, and I've got even more. But so this person, I think this is a male. I didn't dig through to find out all the clinical data on this person, but 110/70, a heart rate of 75. And as soon as that person stand up, there wasn't an immediate drop in blood pressure, right? There also wasn't an immediate raise in heart rate, right? So this person doesn't really meet the formal criteria for orthostatic hypotension, except by 10 minutes, the systolic pressure was 80. So there was just a gradual drop down, lots of signs and symptoms. And then again, the heart rate response was not very vigorous. You'd think there would be a much bigger heart rate response as the blood pressure drops. So next slide. For me, I would start again with intravascular volume, fluids, and solid fluticortisone, midodrine. And in this case, I might consider desmopressin. The way I decide about desmopressin is the intelligence and compliance of the patient, because they really need to know how not to develop hyponatremia and what to do if they get in a situation where they could become hyponatremic. It's very counterintuitive. I tell them, if you ever start vomiting or have diarrhea or have anything that changes your electrolytes and your intravascular volume, stop the desmopressin immediately. And then you can do anything you want to rehydrate. But you can't take in a lot of free water when you are on desmopressin or you'll get hyponatremic. Next slide. So I want to show you these two slides because of the reason I love pyridostigmine. This was the first time I ever used pyridostigmine. And I'm sorry, this is a little interesting, but this is a person who did her own measurements. And so she just did a standing blood pressure and heart rate for me. Okay. We did lots and lots of measurements. So these measurements are her blood pressure and heart rate standing. And I wanted to give you context. So she gets up early in the morning and she takes she'd always been on a little bit of propranolol that wasn't doing very much, 10 milligrams twice a day. But we added pyridostigmine just at 30 milligrams at 6, at 10, and at 2:30. So I want you to look at her 6 a.m. standing vitals. This is what happens when she stands up. Her blood pressure completely drops out. Sorry, I don't have her baseline ones, supine ones. And her heart rate goes to 126 immediately when she stands, when she has nothing on board. So at 10, the 6 a.m. meds are kicking in, right? So you can see already that her blood pressure is a little better and her heart rate's a little better. And then at 3:20, this is after 1, 2, 3 doses of pyridostigmine. Her standing blood pressure is 112/87 and her heart rate is 69. So this was the little miraculous response to pyridostigmine. I've never seen it before. And it completely took her from bedridden to the ability to have 2 or 3 hours of very light upright activity during the day to get out of the house. Unfortunately, the pyridostigmine gave her diarrhea, and in some patients this is a problem. She took Lomotil for a long time because it was so important to her, but finally we just left her on a little smaller dose. We kept her on that. This was eventually we tried her on 63 times a day, but we brought her down to, she's maintained on 30, and we've kept her on it. Next slide. And why is pyridostigmine helpful? I always thought about it as the parasympathetic effects of pyridostigmine, which raises acetylcholine by inactivating acetylcholinesterase. And I think of it as calming the sympathetic nervous system by empowering the parasympathetic nervous system. And I really pick it more often in people who have constipation, right? And dry mouth and kind of slow motility, because sometimes it really helps relieve those symptoms in patients to be on pyridostigmine. I've had people with intractable constipation that we could get going, as well as the effect on their vital signs. And then, of course, there are some sympathetic postganglionic muscarinic receptors particularly sweat glands, but also the innervation of postganglionic neurons in muscles, probably increasing the blood flow to muscles. And David Systrom has shown that giving pyridostigmine helps increase cardiac preload. Next slide. Oops, I think we skipped one. Okay, I want to show you some pre and posts. We do the NASA lean test over and over to assess our interventions and often have patients do it at home. So this is a person that got up, we had her on these meds, but she got up at 5 in the morning and did a NASA lean test before fluids, electrolytes, and medications, just to kind of see what she was at the beginning of the day. So her resting heart rate was around, low 60s, 61 to 64. And you can see that her heart rate immediately went up during the lean test to as high as 110. It always worries me when the heart rate starts coming down. When the heart rate starts coming down, sometimes they're headed to a syncopal episode. So her heart rate went up 46, and her pulse pressure to systolic pressure was 28%. So let's look at her on treatments. This is later in the day at 3:30. We were just trying to see what should she be on. And so she's on midodrine, just low dose of midodrine, oral fluids and sodium, sometimes getting IV fluids. She's on a little bit of propranolol 3 times a day. So if you see, when she's on propranolol, she has a lower resting heart rate, kind of to the low end of what we like, right? 50 to 55. And her heart rate really during the lean test does not go up even as high as 80, barely up to 80 when she's standing. Is this good? I don't know, right? Or we're capping her heart rate. And you can see her blood pressure is pretty stable, right? So the numbers look good. And her heart rate only goes up 40, but it still meets Potts criteria. But look at her perfusion pressure, what I call perfusion pressure, pulse pressure over systolic pressure was only 22%. So below that 25% cutoff. So in this case, I'm not sure, right? If the propranolol is really making her feel better, maybe, but she might need that heart rate boost to a degree, as long as it doesn't become too symptomatic, in order to get the kind of cardiac output and perfusion that will really help her. Next slide. So this is a woman that we looked at when we decided to add pyridostigmine. So she was on fluticortisone and low-dose propranolol. And so the columns on the left show what her home lean test values were before starting pyridostigmine. So lying down, she was 120 over 82 and a heart rate of 85. And then in the blue, you can see that she's got an orthostatic hypertensive response. So she gets this big adrenergic response to standing. Her heart rate goes up to 122. She's very symptomatic. Her blood pressure pops up. This is not really hypertension, really. I do not consider this hypertension. This is an adrenergic surge from orthostatic stress. And her pulse pressure went from 42 to 19, which is a big drop. So then we had her measure 90 minutes after taking 60 milligrams of pyridostigmine. So her blood pressure looked about the same, supine. Heart rate was lower. So the resting heart rate was quite a bit lower on the pyridostigmine. And then when she stood up, you can see she didn't get quite as hypertensive at 8 minutes. And her heart rate went to 98, but not up to 122. So she was a lot less symptomatic with the addition of the pyridostigmine than when she was just on, and she really didn't tolerate higher doses of propranolol. It made her tired, and so we couldn't go higher than that. Next slide. She also does fluids and sodium loading. Okay, this is the same person, and I want to take you through this kind of slowly. I think just ignore the bottom number. She did it twice. She did these measurements twice. And for me, I like that because I'm just making sure we're relatively consistent. So the first sections are on pyridostigmine and propranolol. So you can see that, let's just look at the top, supine and standing. Her blood pressure, supine was 102/75, standing 121/102. And her, if you just look at her pulse pressure or the systolic pressure ratio, she went from acceptable at 26% to 15%. So I think of that as her perfusion. So even though our blood pressure is way up there and her heart rate is up there, she may not be pumping as effectively and perfusing as effectively if this kind of an estimate is right. So when we added the midodrine to her, we wanted to see what that would do. And so I had her do the same measurements 2 hours after taking her midodrine. And I don't know, supine, why her, these are blood pressure variability, but you can see she had a much better pulse pressure. She went from 98/64 for a pulse pressure ratio of 34. And then standing, and this is only 3 minutes, she did not get as high of a blood pressure rush, 121/96. And her heart rate went up to 96 instead of 100. Not that much difference, but if you look at her pulse pressure or systolic pressure ratio, it only went down to 20% instead of 15%. So I think this was really kind of helping her, and symptomatically it helped her as well. Next slide. I know this is kind of complicated, but I'm showing how if you just repeat the test, you can adjust the meds, right? And you can find out what meds work and what interventions are helpful and which ones are not. So in this one, we're asking, does it help to be on the propranolol? So she's on pyridostigmine, midodrine, glucocortisone, and propranolol in the first side on the left. And you can see her supine blood pressure, 98/63, went up to 118/94 standing at 3 minutes. Her heart rate went 46 to 76. And that pulse pressure to systolic pressure ratio went from 35 to 20%. When we stopped the propranolol and repeated these measurements, her resting heart rate was higher. It went higher. It was at 52. It went quite a bit higher at 3 minutes standing to 97. And her pulse pressure to systolic pressure ratio went from 36 to 14%. So I think, assuming she does tolerate that lower resting heart rate, it seems like she does better with the addition of propranolol to her regimen, and it makes her feel better. And the lower numbers, the repeat tests, were just to kind of confirm that we were on the right track. Next slide. The other point I wanted to make here is that the presentation of orthostatic intolerance changes with age and time. And I think we take this for granted. We send someone for a tilt table test and label them with POTS or with whatever. But 5 years later, especially if they go from around 18 to 22 up to a lot older, when there's a lot of difference in the sympathetic nervous system and the response to orthostatic stress. So when this young man I saw him when I saw him first when he was 16. We didn't really start doing a lot of orthostatic testing until he was 20, and I sent him for a tilt table test, and he didn't make it 3 minutes on the tilt table test. So his supine numbers look good. 3 minutes, he experienced neurally mediated hypotension and fainted, and they had to take him off the table. So we treated him, this was back around 2004, 2005. We treated him with fluticasone and midodrine, but over time, he kind of fell away from them and didn't use them. And, he was, so when he was 34, I decided that we were going to do a Nasoline test and see what was going on with him. He was no longer on any of those medications, not super symptomatic, but you can see that his standing blood pressure has that hypertensive response, that adrenergic response. So there's an orthostatic stress going on, and his heart rate went up from 57 to 72. And if you look at his ratio, the pulse pressure to systolic pressure, supine was 38, but when he stood up, that ratio went down to 17%. So I think he still has pretty significant orthostatic intolerance, and he does by history. So he can't stand in place very long. He doesn't take hot showers. He gets washed out if he gets overheated. So we've ramped up his fluids and see if we can get him doing a little better without adding a lot of medications to him. Next slide. So this is another person on and off meds. So on the meds, on the left, he was on ivabradine, desmopressin just at night. By the way, desmopressin can help preserve your fluids so you don't lose fluids overnight, but doesn't cause many of those risks. So people who have urinary frequency and tend to wake up really dehydrated, sometimes desmopressin at night helps them, save that fluid in their tank and get started with a bit better intravascular volume in the morning. He also was on a high dose of propranolol from another doctor. We put him on some pyridostigmine, and you can see his heart rate went from around 70 up to 84, 90. He was dizzy, and his this is on his meds. Sorry, it really did not go up very much on the meds. Sorry, I'm getting backwards here. So he had a pretty good control of that. And this is to help him understand whether his meds were helping or not, right? So on the right, we stopped his meds. He wanted to see how much they were helping. And you can see his resting. I'm not sure, how much of this is rebound from going off the meds, but his resting heart rate was down in the 50s and then went up to 117 when he stood up. And his blood pressure also marched down. You can see started out 112 over 66. And, as the tests progressed, his blood pressure gradually dropped. So this helped him understand that the things that we were doing were probably making a difference. I have to say, though, the pulse pressure over systolic pressure ratio did not change at all, right? But it stayed in a good range. So even though he had a rapid heart rate response, that was making him feel very symptomatic. So this is a tool we can use, but it isn't always the parameter. I like to use every parameter, the heart rate, the blood pressure, and then looking at the ratios as well. But see how much more symptomatic he is off of his meds. Okay, that's the end of those slides. But let's go one more. I just want to show you my most difficult patient. This person, nothing we've done helps her. So these are the supine values on top. So she's kind of bordering on hypertensive supine. This is on all of her meds. She's on various meds. She doesn't tolerate a lot of meds. As soon as she stands, her blood pressure drops. So you can see by 8 minutes, it's 86 over 67. And her heart rate goes up to 122. And then when she gets supine again. And she's been our hardest patient, my hardest patient to get any kind of control under. Okay, we can turn off the slides.